Afternoon, everyone. My name is Vicky Bowden. I am the project manager here in HOPP, our Human Oncology Pathogenesis program, and I'd like to welcome you to our summer research seminar series. We're excited to have you all join us this afternoon. And this afternoon we have guest speaker, Dr. Melissa Murray, and she will be discussing the diagnosing cancer, the role of pathology. Just to give you a bit of reference who Dr. Murray is, she's an associate attending pathologist and the director of the Oncologic Surgical Pathology Fellowship here at Memorial Sloan Kettering Cancer Center, and with a clinical practice focused exclusively on the diagnosis of breast lesions. She received her Doctor of Osteopathic Medicine degree from Philadelphia College of Osteopathic Medicine. She completed residency training in Anatomic and Clinical Pathology at New York Presbyterian Weill Cornell Medicine, and also completed a Breast Pathology Fellowship here at Memorial Sloan Kettering Cancer Center. We're excited to have Dr. Murray with us this afternoon. Thank you again, and welcome, Dr. Murray.
Thank you very much for that nice introduction. Hello, everybody. So I'm going to talk to you about the role of pathology in diagnosing cancer. And part of this, let's see, there we go, is also just, I know that maybe this is a mixed crowd, but kind of focused and geared towards high school students. And I give some other lectures to high school students specifically about pathology and the career in pathology. So I'm just hoping today to introduce you to what pathology is, explain it a little more in depth, share some interesting advances and an interesting case at the end of the presentation. But I think pathology is a really exciting career within medicine. As mentioned, I went to Osteopathic Medical School in Philadelphia. I did my residency across the street at Cornell in pathology. And there are many different career options under the umbrella of pathology. And one of the reasons I'm even hyping this is because we definitely have somewhat of an issue in pathology where I think the way medical school education has been sort of redesigned, pathology has been pushed a little more out of it. I don't think medical students these days get exposed to it in the same way that it was taught, say, 15, 20 years ago. And so we have a pipeline issue. Not as many people seem to be picking pathology as a career path within medicine. So we're definitely making more efforts to get the word out there. So you have been cured by a pathologist if you've ever had blood tests, peed in a cup, had any kind of biopsy or surgery. So pathology in general, and most people, like I say, I did my pathology residency at Cornell. What I did was a residency in both anatomic and clinical pathology. So anatomic, or the surgical pathology side, is looking at the tissues, right? And so we learn how to look at the histology of all tissues in the human body, as well as we learn some forensic, not forensics so much. You can do rotations in forensic, but part of your requirement for graduating from a pathology residency is that you have to do 50 autopsies. So you also learn about autopsy pathology, molecular genetics as part of pathology, and then I have a combined degree in anatomic and clinical pathology. So clinical pathology is blood banking, clinical chemistry that's done in the lab, microbiology, and you get certified within 4 years in all of these areas, and licensed to be what we call an AP and a CP pathologist. And then you can go on and subspecialize. So for me, I was more interested in the anatomic pathology, and I went on and did a breast fellowship here at Sloan Kettering and then stayed on here. But out in the community, many people are primarily anatomic pathologists, but they also have to cover one role of clinical pathology. So they they may be in charge of clinical chemistry. And in the labs, you work with like a very diverse and large workforce. And you are a significant component of disease management teams for the patients. So there are opportunities to interact with patients face-to-face, though they are few in the world of pathology. But you are a behind-the-scenes, very important doctor in the patient's care. So forensic pathology is specifically what we kind of see on TV, where you're investigating suspicious or undetermined causes of death, sudden death. They evaluate corpses, determine the cause of death. I work closely with law enforcement to determine the manner and again, the cause. Forensic pathologists are required to appear in court from time to time to explain autopsy findings. And all, like I mentioned, all anatomic pathology residents are required to participate in a specified number of autopsies by the end of their residency. Cytopathology is another sort of subspecialty that comes under anatomic pathology. And this is actually looking at tissue, like really just at the cellular level, right? So this is where you use either like a fine needle, or you might be taking fluid out of a patient and spinning it down so that you can see what kind of cells are in that fluid. Fine needles, obviously, I don't know, you sometimes can have a small, say, a mass on your thyroid gland, and they can just sample it with a very fine needle. You don't have to undergo any anesthesia. They put those cells on a slide. And so you're getting a disbursement of like the single cells that are coming out of that organ or that mass. And then you're looking at them under the microscope. So here you're really looking at like very subtle cellular features to distinguish malignant from benign. And you're also able to classify like where these cells, which organ these cells came from, just based on looking at these few single cells that you may see. And that can be really helpful in directing whether you should take, if it's benign, maybe that's it, the patient can go home, or if it's suspicious looking or malignant looking, then it's time to move forward to like a more invasive biopsy. Surgical pathology. So the primary components include, when you're a surgical pathologist, you learn about gross dissection, right? So this is tissues that are coming out of patients like you're in the OR, right? So removal of this here is the gross specimen of a liver, right? So somebody had their liver removed. It's been sectioned in the pathology lab. Obviously, you can see this here is the liver, and you can see here that there is a large mass here. So what you learn about in your gross pathology is you need to know what sections to take when you're looking at a big piece of tissue to give us the right information when we look at these under the microscope, when we look at them as in the slide form, right? And this is extremely important. Not only are we potentially diagnosing what this tumor is, but we're also would be looking to see, does the tumor go all the way to the edge of the tissue, to the margin? Like the surgeon thought that they took out the whole tumor, but maybe they didn't. Maybe microscopically on the slide, we'll see that there are cells that reach the area that was cut out. And that would be an indication then to the surgeon that they have to go back and remove more tissue. So there's really a lot of different components that we're adding besides just the diagnosis. Many tumors may have certain markers that will indicate that they would be responsive to particular treatments. And so that's done in our laboratory, right? Immunohistochemical staining and special studies that can help us further define what the best treatment is for a particular type of tumor. Pathology is really one of the significant components in staging a patient, right? So for patients with cancer, what stage is it? 1, 2, 3, 4. A lot of that has to do with the size of the tumor, involvement of lymph nodes, has the tumor spread. So an accurate pathology report is really crucial. to getting like a precise diagnosis and deciding on the best treatment plan for the patients. So another component that's more recent and definitely taking off significantly is actual digital pathology applications, right? So for the most part, here this slide, so let me just go back. This slide is to show, this is a slide that's been scanned, and then this is the computer screen here. So we do have the capability, and at Memorial Sloan Kettering, our program of digital scanning is pretty robust. So as the slides are processed in the lab, they can be run through a slide scanner, and then we have the option of looking at the slides either via our computer screens and scrolling around, and we can zoom in and out just like we would move objectives on our microscope, or we can look at the physical glass slide. So obviously some of the advantage for digital scanning is that one thing significant is it helps it potentially in the future decreasing the amount of, these are tissue slide blocks, and these are the actual slides that we would look at under the microscope. So maybe we would be moving forward to not having, when we need second opinions, having to send out these tissue blocks. We could just send the digital images to other pathologists and get second opinions. We actually use this now here. This is the main hospital building at 1275 York Avenue. And then this is the Josie Robertson building, which is the same day surgery center of Sloan Kettering that's down on 61st Street. So we have pathologists that are doing frozen sections at the main building, and we have pathologists doing frozen sections at the Josie Robertson Surgery Center. So if you have a question, when you're at the main building, if you have a question and you want a colleague to look at a particular slide and help you with the diagnosis, it's pretty easy because most of our offices are here and you can track somebody down. But down at Josie, you're the only pathologist assigned there for the day. There are no other pathologists there to consult with. So using our digital scanner, we can show the slide. There's a camera attached to the microscope, and I can call somebody who's in their office, whatever, like 7 blocks up at the main building, and ask them to review the slide with me. So this makes, second opinion consults much, much easier. And someday, who knows, maybe we'll be able to, do more significant work from home because we'll be able to look at imaging, most of our cases digitally. Digital pathology also, and the digitation of glass slides, the pixelated data can be used for machine learning. And this is being done, and great advancements in this area are happening right now. The machine learning has been shown to improve the efficiency and accuracy of cancer detection in a variety of tissue types. So this is a situation where the slides are scanned and then they're run through like a machine learning, a computer system that has been taught to look for cancer in particular tissue types. Then the pathologist can come in and all the slides for the case can be there, and they're already pre-screened by the computer, and the computer has already highlighted areas that they think are atypical and sort of point the pathologist to confirm, like, yes or no, this is atypical. There's also a lot of applications for this in learning different components of there's just a lot of information that can come out of the imaging of the cells and coordinating it with particular stains, particular mutations, and gathering all that information, clinical information, historical information into the computer. And we really believe that this is going to help us learn more about tumors in depth. So, for machine learning, they go through, obviously training. You have tissue here. Usually this is a physical part, but where somebody actually outlines like all the tissues so that the computer can learn like what is tissue, what is not tissue. And then here outlined in red, it's showing you the tumor that's been outlined. So teaching the computer, normal versus tumor. And then here, this is what I was explaining. You have this whole slide that's been imaged. It's on the computer. It goes through the machine learning. It evaluates overlapping pixels and images. And then this is what it would look like when it's telling you that they believe they see that the machine believes it sees an abnormality. It highlights it here. And that is true. This is an area of cancer here. So this has already been FDA approved for prostate biopsies. We already have a system in place for lymph nodes in breast cancer. So looking for breast cancer metastasis to lymph nodes. And we're piloting that right now. And I think that this is really going to expand a lot in the next few years. So another component of anatomic pathology and what we do here is what's called frozen sections. So here you're working essentially, you're not sitting in the OR room, but you're sitting in a lab right near the OR. And so the surgeons will send small pieces of tissue over from the operation, and they're going to say, like, I need to know what this is. I felt this unusual bump and I need to know if this is cancer or not. Like if it's cancer, then we're going to stop the surgery. It means the patient, has more extensive disease than we believed. Or I mentioned like margins. So the surgeon might send the margin tissue up to you. And what we can do is we can actually freeze the tissue and get a slide within like 15 to 20 minutes. The pathologist can look at it and then we report into the OR our findings. So this is definitely probably, one of the more like high intense, stressful components, right? Because you have the patient waiting on the table, anesthesia is ongoing. Sometimes they're not, sometimes they're continuing to work while they're waiting for your diagnosis, but sometimes they're just waiting for that diagnosis. And that's going to tell them whether or not they're going to move forward, whether or not they're going to take more tissue. So these obviously diagnoses need to be accurate, and it's a significant part of helping guide the surgeon's hand to doing the correct procedure. And this is just showing you an example. I'm specifically a breast pathologist. So this is pathologists learn. And as I mentioned, the machines are learning these days. What are benign? This is what we call a benign breast lobule. And these are the ducts out here. For instance, when a woman's pregnant, milk is made within the lobule and then it travels through to the nipple through the ducts. These each have 2 cell layers. And then this is cancer. It looks very different, right? It doesn't maintain the normal structure of the female breast. The cells are much larger. This is at a higher magnification, but you can tell that like the nuclei of these cells are much larger. They're invading through the stromal tissue in a way that they're not, is not normal. They're not supposed to. And so this is an example of invasive ductal carcinoma of the breast. And finally, another component, molecular genetics, I mentioned briefly in the beginning of the talk, but molecular pathology is also a field that has been rapidly changing and growing and changing the way we treat cancer. We here at Sloan Kettering have a specific test. It's called the MSK impact test. So almost all of our tumors, this has to be done with consent. The patient has to consent to having this test done. But this test is based on massively parallel next generation sequencing. So this is cutting edge technology that allows cancer genomes to be profiled very quickly with great sensitivity. The test has about 500 specific genes that it looks for. These are known cancer causing genes and sort of related genes that we find. And genes, the test started out with about 350 genes, and now we're up to over 500 genes. So things can continually be added as more information comes out from research. So what they do is they get consent from the patient, they have tumor sample, and they take a sample of the patient's blood. They prepare in the lab, they take, the DNA and RNA separated out. They put it through the sequencer. They get a bioinformatic analysis. The case is reviewed and signed out by our molecular pathologists. And then all of this genetic information goes into a specific database where they're tracking all the different mutations that are found with specific tumors. It generates a clinical report. And then this is really one of the key things, this clinical trial matching. So we have had cases where, there's been a thyroid tumor, and we know that thyroid tumors have this BRAF mutation. And then there is like a soft tissue sarcoma that nobody really thought or knew that they had BRAF mutations, but this, impact test tells us, oh, this tumor has a BRAF mutation. So we have a trial for medicine targeting BRAF mutations. And, normally you wouldn't have put that sarcoma patient into that trial, but now that we know that there's that mutation there, that patient has the opportunity to enter into this trial and see if the medicine will work because they have that specific mutation. And then obviously most of this information, not the patient information, but the blinded information about tumors and their specific genetic mutations that are found are put out on public databases. So the information can be used by researchers and scientists all over the world. And it's a great way to advance research at a quicker pace. And so through this CBio portal, different people can go data mining and look for, interpretation of all the data that's produced. So, our department has grown dramatically. There are a lot of areas that are rapidly growing. Not everybody who's a physician or a doctor in our department is necessarily an anatomic and pathology trained pathologist. We have a lot of PhD doctors that help us with the bioinformatic analysis, and just a lot of different people that work on all these different aspects of, trying to get the best cancer care. So this is sort of what I said, that finding a specific mutation can lead to a clinical trial, and that may be the best treatment option that was unknown for the patient. And of course, there are many genes that may be changes that might be detected by the test, but it doesn't mean that they're not actionable. We don't have a specific treatment for them. But over time, as like I said, the data mining, and if you start to see specific trends and people are working on specific treatments for different genes that may come to light, you can always go back, say the patient has a tumor recur. And now we do have a treatment, for a specific mutation that we didn't have 5 years ago. So it's just really helpful for giving us lots of data and lots of opportunities to help future patients. So most effective cancer treatment starts with an accurate diagnosis, right? And that's what pathology is here to do. And I just thought that I would give you an example by showing you an interesting case. So there was this patient who was 15 years old, female. She had an excision of a mass that was diagnosed as a benign fibroadenoma. Now, we actually didn't have the opportunity to review this original diagnosis. This was done actually, this is an international patient, so this was done at their home country. Here, I've just shown us a picture of what a fibroadenoma is. These are neoplasms, meaning, Chris, it's an abnormal growth, but it's benign. It's not a malignant lesion. But you have growth and expansion of both components of the breast, the fibro, like the stromal component, and the adenoma refers to the epithelial component. So, you get this rounded tumor in the breast. Sometimes these are palpable. They can happen in young women. They can happen at any age. Most commonly, it's women that are in their 30s. They may be palpable and lead to a biopsy. They may be smaller, not palpable, and found on imaging and lead to a biopsy. And as I said, they're benign. So this one happened to be excised, but they don't all need to be excised. So this patient had a mass. It was diagnosed as a fibroadenoma. This is what we know from the history from the report. She went ahead and had the mass removed. As I said, it was an international case. So like at her home hospital, she had the fibroadenoma removed. 1 year later, the lump returned in the same area. So they decided to take it out again. And now it was called carcinoma of the breast. She was given 3 cycles of chemotherapy and did not have a satisfactory response. So they went on and did a left breast mastectomy, an axillary clearance. That means that they went ahead and took off, surgically removed her left breast, and they evaluated the lymph nodes that are in the axilla of her left armpit. They went ahead and gave her an additional 4 cycles of a different type of chemotherapy. 2 years later, she started to develop nodules in the supraclavicular and axillary areas. So supraclavicular is sort of like around your clavicle bone, right? Above and below. And again, axilla is the area of your armpit. They did a biopsy, and now it was diagnosed as secretory carcinoma, a specific type of breast cancer. This diagnosis had not been made previously. They went ahead and gave more chemotherapy. She really was not responding to it, and she had been lost to follow-up for 6 months. So when she came back, unfortunately, you can see here, so these are images from CT scans. What you're looking at here, this is the patient's chest. These are the lungs of the patients. That's the spine. So these are the ribs here. So looking at the chest wall, you can see that there is this massive growth here, right? It had not been responding to chemotherapy. She stopped treatment for at least 6 months, and the tumor continued to grow. Unfortunately, also, when they went through imaging, they saw that she had multiple bilateral lung metastases. So the tumor had spread and was involving both of her lungs. This is what secretory carcinoma looks like. It looks different than the other breast carcinoma that I had shown you. It has this very specific look of all of these vacuoles, which have secretory contents within them. So it's very what we call vacuolated. It's usually very eosinophilic. That eosinophilic is the pink stain that the cells pick up when we stain it. We stain our slides with eosin, which is pink, and hematoxylin, which is blue. So the blue, these circles here are nuclei of the cells, and this is all tumor cells, specifically a secretory carcinoma. And secretory carcinoma is known to occur in young women. It really can occur at any age. By the textbook, it's usually said that it's more common in like very young women, and then like very at the older age, in your 70s and 80s, but it can occur, at any age. So in breast cancer, I had mentioned briefly that part of what pathologists do is sort of tests that may help predict medicines that might be used in the treatment of the patient. And so breast tumors may be hormone positive, hormone receptor positive, or negative. So this is estrogen receptor, progesterone receptor, and these were both negative. The staining pattern that's done, it's different. It's not hematoxylin and eosin. It's a brown is the antibody that in this case for estrogen receptor, it's localized to the nucleus of the cell. So this is the positive control. It's showing that this tumor here is estrogen receptor positive. Again, the positive control for the PR, the progesterone receptor. So if these were positive, it would tell the oncologist that they could use anti-estrogen type medicines that are available to treat this patient. And then HER2 stands for Herceptin. This is an EGFR receptor. And we have a specific medicine called Herceptin that treats HER2 positive tumors. So this is not a nuclear stain. This is a stain. Herceptin is localized to the membranes of the cell. That's why it looks different here in the positive control. So this patient's tumor is what we call triple negative, ER, PR, and HER2 negative. So the medicines that we have that treat positive tumors, they're not going to work for this patient. And it also helps us classify tumors when we know their ER, PR, and HER2 status. And secretory carcinomas are triple negative. So that goes along with our impression from the H&E stain slide. So secretory carcinoma in general, it accounts for less than 0.15% of all breast cancers. It's very rare. The median age of presentation is 25 years, and the age range, as I said, is from 3 years old to 87 years old. It predominantly affects females, but it can be seen in males, and that's specifically male breast cancer. The average size is about 3 centimeters. Radiologically, it's seen as a solitary discrete tumor. It has smooth or irregular borders, and there's no particular distinguishing features for it radiologically. Grossly, so that's what we say, like when you take the tissue out, when you cut the breast tissue out, and what the tissue looks like, you usually see a circumscribed, firm mass. Rarely it has infiltrative margins. So we're saying like it doesn't look like it's creeping out into the breast tissue. It looks more circumscribed, sort of like that fibroadenoma that I showed earlier, where it's very rounded. So one thing that we know about secretory carcinomas, which has been learned, we've known this since 2002, is that they have a specific gene fusion. And this is considered the primary event in human secretory carcinomas. You have this ETV6 and TRAC3 gene fusion. And so secretory carcinomas express this gene fusion. Here you can see it's a fusion between chromosome 12 and 15. And we have a FISH test. So FISH is fluorescent in situ hybridization. So they can use probes. Here you see a normal cell, a normal example of, the chromosome 15, chromosome 12. And here you can see that they've combined. And so they've fused together. And that's an indication that this ETV6 and TREC3 fusion is there. Confirmation that we have the fusion. So in this study here, they showed that the expression was confirmed in 12 out of 13 secretory breast carcinoma cases, and it was not seen in other ductal invasive carcinomas of the breast. So this was very specific for secretory carcinoma and helpful in confirming the diagnosis, confirming your impression from the microscopic slides. This ETV6 and TRAC has actually been found in several different tumor types and really varying different tumor types. So you can see it in something called a congenital mesoblastic nephroma, which is a spindle cell tumor of the kidney. It can be seen in infant fibrosarcoma, another spindle cell tumor in the extremities, right? So this is a sarcoma, like the soft tissue. It can be seen in acute myelogenous leukemia, AML. This is one case with a variant that's been reported, and obviously secretory breast carcinoma. So very different, but the same fusion. And that's what I was talking about when I mentioned the MSK impact, is sometimes that test has led us to discover sort of in a faster way that certain mutations may be found in very different tumors, different tumor sites. And if we have a treatment for them, then we can attempt to use that treatment. So this is particularly important because there were small cell molecule inhibitors that can be used for this ETV6 and TRAC infusion. So this is just talking about specifically a phase 1 study of this LOXO 101, which is an inhibitor of that fusion gene. And so can be attempted to be used in patients with NTRK. They saw that there was partial response in 6 out of 6 patients. Now, again, this is a phase 1 study. So this means that this is the earliest phase of testing the drug. And the drug is on the market these days. But so they had different tumors, all had the ETV6 and track fusion, and they were seeing some response from this small cell inhibitor. So back to the patient. As I mentioned, this was an international patient, and all of that initial, cancer, initial diagnosis, chemotherapy, the recurrence, eventually getting a diagnosis of secretory carcinoma, being lost to follow-up into treatment for at least 6 months, coming back with much more disease. You can see here, so coming back with much more disease and finally making their way to New York and to Memorial Sloan Kettering for an opinion and options for treatment. So this is a PET scan here. In September, you can see here's that big mass that we saw previously on the PET CT, and you can see all these small black lesions are tumor in the lungs. This is just sometimes there's normal molecules that are used in the PET scan may be secreted through the bladder. And so that's why this is highlighting here. But all this tumor here, secretory carcinoma, we confirmed at our hospital that it had the fusion that we expected it to have. We did have this medicine that had been, in trial. The patient was put on the trial, started on this Loxo 101, and this was reevaluation 1 month later. So you can see significant, marked reduction in this tumor. The lungs look pretty much totally clear. There seems to be some residual disease here, but this was just in 1 month. The treatment was not over at that point. The patient was going to be continuing on to treatment. So just really a dramatic case of showing you that diagnosis of secretory carcinoma, right, made a huge difference in the way this patient was treated. The fact, even if we didn't know that secretory carcinoma had that gene fusion, patients come and, as I said, they have their tumors. We recommend that their tumors be evaluated by the MSK impact, the sequencing tests that we have that may lead to results that we didn't know necessarily existed. So an ETV and track fusion in another tumor that we hadn't seen it in that type of tumor before. If it comes up, even if it's just for that one patient has this fusion, they can try the medicine on this patient and see if it helps for that particular patient and that particular tumor type. And then they can go back and test, maybe patients in the past that didn't have the MSK impact testing or specific testing, FISH testing for a particular fusion. If a patient comes back with a recurrence of their tumor, then they can say, hey, you know what, we've learned that some of these types of tumors, like say it's a kidney tumor, have this NTRK fusion. So why don't we test your tumor now? Pathology, I showed you there were all those tissue blocks in the slides. That material, at least here at Sloan Kettering, we keep that material forever. We have warehouses all over the city with, slides and blocks, tissue samples. So we can always go back and test the patient's tumor if the material is properly stored and still there's tumor left behind. So why pathology? It's really central to patient care. Even though you're a physician acting behind the scenes, you're interacting with the other physicians, the surgeons, the oncology team, radiology continuously. I don't want you to think of it as we're just hiding here in our office and behind the scenes. You're interacting with people all the time. There's really a wide variety of positions that you can hold, whether you do surgical pathology or you decide that you just want to do a clinical pathology, a combination of the two. Pathologists are really at the forefront of medical research and discovery. There are specialists in molecular studies. Cytogenetics is another component that falls under pathology. And we're really making great leaps and bounds, as a team with our other colleagues for personalization of medicine and treatment. It's challenging. It's constantly evolving and exciting. And a career in pathology allows for a very healthy work-life balance. You do have time for family and friends and hobbies. That is the one thing. Some people, maybe really, and I appreciate that, want that patient-to-patient interaction. But, if I am on service and I have a stack of slides that I'm, need to look at and get those reports out, which we do, in a timely fashion. But, oh, something happened that morning, my kid was sick or something, and now I have to wait an hour or two for a babysitter to show up. It's okay because I just have slides waiting for me. I don't have a room of patients waiting to be seen. So it's a little bit easier to sort of manage your time and your lifestyle. There are, we do cover call, but being called is very infrequent, and that varies with the type of the specific like subspecialty that you go into. But it is good lifestyle. Okay. And I'm going to end my talk there. I'm happy to take any questions.
Great. Thank you so much, Dr. Murray. We do have some questions here in the Q&A. The first is, what inspired you to become a pathologist in the first place? Did you know all of its benefits beforehand?
That's a great question. So personally, I graduated college thinking I was going to go into physical therapy. So I was sort of interested in healthcare. But before I did that, I actually got a job here at Sloan Kettering as a research assistant. That kind of opened up my eyes. I think I had a very narrow view of what being a physician was. I didn't have any physicians in my family. I really didn't know anyone personally who was a doctor. And the thought of sort of working all the time and being on call and pulled away from your family, I didn't like the idea of any of that. But working at Sloan Kettering as a research technician, I sort of started to understand and realize that there are many different types of doctors, and their lifestyles are different. You can do research solely, even if you go through medical school. So there are many different types of things that you can do, and it was really varied. And I was sort of, it grew on me, and I decided to go to medical school. I don't know. So maybe I think that experience working for 3 years and working here at the hospital, it gave me a little bit better exposure. I did learn through like the research I was doing a little bit more about pathology. I still went into medical school thinking that I might be a family doctor. That's what I was thinking when I first started. I had a really fabulous pathology teacher. It was a whole course for us. As I said, nowadays it's kind of like a lot of medical schools taught by like organ system now. So pathology is like incorporated into like when you're studying GI, you learn some GI pathology, but it really, I don't know. I don't think it comes across the same. So I had a great teacher in my course of pathology. I was good at histology. We do anatomy, histology in medical school. I just started to realize that as I was going through with my personality, how I wanted my life to be, I started to see that pathology was probably going to be a better fit for me. And so then I did electives in pathology, just talked to more people while I was in my first couple of years of medical school. And by the time early in my third year, usually you do your first 2 years of mostly coursework, and third and fourth are when you're out in the hospitals doing rotations. I made sure to make pathology like sort of my elective rotations. And I decided it helped me make the decision that was the right fit for me.
Okay, great. Thank you so much. The next question is, what other effects did the treatment have on the girl from the example case that you shared?
That's a really great question. I don't specifically know. I mean, you're saying like, what are the side effects of that medicine? I I don't know. A lot of times these specific small inhibitor medicines, and like also, right, immunotherapy is big now. The side effects are a little bit more mild than the harsh chemotherapies that we used to use. But I don't know the answer to that. I don't know what the side effects of that medicine are. I can tell you though that the tumor did eventually clear, and at follow-up like a year later, that's as far as I know. I should look more recently, but the patient was still clear and free of tumor.
The next question is, why is it that there are less people going into pathology?
That's a great question. As I said, I think that it really varies. I think sometimes people, one is, I think it's exposure. I think maybe pathology is not being highlighted as well in medical school. Pathology is not like doing a rotation in pathology when you're in your third and your fourth year. It's not a standard rotation. As I mentioned, like I had to do it as electives. So unless you like seek it out, you really may not be exposed and understand like what the lifestyle is and what, the actual day-to-day work is. I think also for a lot of people, they don't go through medical school and learning about taking care of patients. It's not seen as like as sexy a subspecialty to go into. I think for some people, just having that person-to-person, like patient to doctor connection is something that they're craving, and they want to be able to see the patients that they're helping, interact with the patients that they're helping. I don't need that. I personally know that I am, a significant part of the patient's treatment and treatment plan. I certainly know like my colleagues, the surgeons, the medical oncologists that I work with appreciate the work that I do. We reevaluate any patient that comes to Sloan Kettering. If they've had pathology done outside, it all has to be re-reviewed here before they can have treatment. So sometimes we catch, errors or mistakes, and it makes a big deal and a big difference between the treatment that the patient's going to have, or maybe the patient doesn't even need treatment. Maybe they don't really have cancer. And so I get the feedback from the people that I work with, like, oh, that's great that you caught this, this is really great. This will help the patient a lot. I don't miss out on like the patient doctor interaction, but I think that's important for a lot of people, which is completely respectable. Just because you don't have the patient doctor interaction, it doesn't mean you're not interacting with people. As I said, like I'm interacting with my colleagues all the time. We have a lot of trainees. I'm the head of our surgical pathology fellowship here at Sloan Kettering. So I love that too. I get to do a lot of teaching and interact with our fellows every year. So, I think it's not really being highlighted as well in medical school. It's not a traditional rotation that you go through. So I think people, and you're not seeing patients on a daily basis. So for some patients, for some students, it's just not their bag.
Great. That's a good point. Actually, our interns for our summer student program, they actually did a tour of the pathology department on Monday. And it's really important for them to realize, like, you guys are the ones that help confirm where to go next, right?
Right.
You guys are like the front line, and it's like a domino effect. And we know with medicine and specifically with oncology, it's like a team effort. So I do agree, the more exposure there is, hopefully that'll inform the next generation of pathologists. So to continue on with questions, we have, what would you say is the most important piece of advice you can give to anybody who is looking to get into pathology?
Good question. I would say, I'm sorry about that. I would say, that's my alarm for a conference. I would say, so So, I mentioned that I worked before I actually went to medical school, and there's actually, everybody has a different path. So firstly, I guess if you're in medical school or you're going into medical school, well, now you all know who I am, so you could always reach out. I don't know, I think our information is on the web. You could always reach out and be like, hey, I'm interested, I want to shadow somebody. We have people who come through as observers. So there's that. Like if you have it, you've been introduced to it, so you have it. When you go through medical school, sort of remembering that it may not be, the opportunities may not seem to be there to, spend a lot of time in pathology, but you can seek it out. You can speak up and ask and, tell your mentors, your teachers that you're interested or you want a little more exposure to it. In terms of like working, like if before you get to medical school, there are a lot of jobs associated with pathology where you don't have to go to medical school, like all the technicians that work in our labs that help us make these slides. Also, there's something called pathology. You can be a pathology assistant. You know how there are physician assistants? We have specifically pathology assistants. They go to a specific school program. Like I think you have to go to college and then you go to pathology assistant school, which I think is 2 years. I should confirm that. But and you can do what they don't really learn there is they don't learn like looking at the histology and the microscope, but they learn how to do all of the grossing and all the prepping of the tissue for what slides are going to be given to me. So I don't actually do much gross pathology anymore because our gross room is run by pathology assistants. And they're also like, what they do is key because I don't go and look at every specimen that they're working on, but they know what they're supposed to do. They've learned like how to do it. They've had a lot of training. And what they do, then I get the slides that they've chosen that are supposed to be the right slides to help me make the correct report. Of course, if I feel like I'm missing something, we can always go back and add more. But just to say that's a very, very, very important role that they have. They don't have to go through medical school and residency, and like fellowship. But they're also a significant part of the pathology team. That's called a pathology assistant. So, if you're interested, if you go to medical school and you're interested, I think that you probably have to speak up for yourself a bit to get more exposure to pathology. Yeah, I hope that answers the question.
Great, thank you. I do know you have a conference.
No, that's okay. Don't worry.
Oh, okay. So the next question they ask is, how much would you weigh the usage of computational work versus like traditional pathology? For example, is it 40 to 60 of computational versus traditional pathology?
So, what I do is almost 100% like traditional pathology, but what my colleagues in molecular pathology do, it's probably, so even molecular pathology, like, yes, you have to look at a slide and you have to mark where the tumor is so that you're, getting the DNA from the right cells. But then it's getting the DNA and putting it through the system and the computational biology. So there, the computational biology component is significant, like for molecular pathology. So it really sort of varies depending on like kind of what you do in pathology. In some areas, it can be, yes, at least like 40 to 50% of what is done.
Okay, great. And the next question is, how large of a role do you think AI will play in pathology in the future?
I think it will play a significant role. Now, I'm not concerned about my job going away. Every time like new technology and you digitize things, for a long time, a human is still going to have to confirm that, yes, that is tumor. What we really think is like humans are good at doing pathology. The machine is good at doing pathology, but not better than the human. But the human and the machine together are probably better than the human alone. I think that like that's the way we generally think of it here. Like, this is going to be a tool that's going to allow us to work more efficiently on some levels. We'll maybe be able to get through more slides faster with, as I described, like this, when the system has already like pre-screened the slides. There's that. I really think that with, immunochemistry, immunoplexing different molecules onto cells and having the machines be able to read these slides and figure out like certain molecules specific for certain cells, like, and all the information that's going to come from that. I really think this AI and the digitizing, it's going to help us get like even more information out of these tumors in a different view with all of this. So I just think it's going to, it'll only assist us and make us better. I'm not concerned about it taking over.
Okay, great. And the last question, Anthony asks, what would you say is the best aspect of your job as a pathologist?
I would say, for me, it's looking at the slides. Like it's looking at the slides is like, it's exciting. Breast pathology specifically has, for malpractice, like, right, for making a mistake, because breast cancer is so common, and breast biopsies are so common, it's one of the fields within pathology that probably has like the highest malpractice rate. I feel like I should knock on wood, right? So this is a big deal. Like, you can't, of course, in the end, people make mistakes. The degree of mistakes that happen, varies. Hopefully you don't make a very big mistake. But my point is that it's challenging to look at the slides. Even though I've been doing it for like more than 15 years, there's always something new that comes up, or something that's still hard to distinguish, that I may have to show my colleagues, or tumors that don't act the way you expect them to. So it's just still really like a variety. That we have a fellowship, which is, a specialized training. The fellows preview the slides before they bring them to me. So I sit at my scope every morning with a different fellow, and I get to teach them. And I don't know what's going to be in that stack of slides. We may have like a really rare tumor, some of it may be sort of the routine stuff, but it's always sort of a surprise at what we're going to get. And then, there's always that challenge that, you're doing this correctly, you're not missing anything. So it just makes it exciting overall. And then on top of all the new advancements that we've been doing, and I'm not gonna, I'll say my lifestyle, for me, that was an important part of, making the decision of whether I wanted to go to medical school and what type of physician I wanted to be. And, it definitely is a good work-life balance in pathology.
Great. Thank you so much, Dr. Murray, for today's lecture. And thank you for our attendees for joining us this afternoon.